at UTH. Let me introduce to you today our speaker. Our speaker today is Dr. Lorraine Shishimba. She is a consultant in neurology at UTH. People who have been with us for the last 3 weeks will recognize her as one of our subject matter experts from the last 2 weeks. She is one of Zambia's first neurologists, trained neurologists, was part of the first cohort of trained neurologists in the country. And her particular area of interest and expertise is in movement disorders. Today, she will be taking us through history taking and the neurologic exam. So with that, I will hand it over to Dr. Chishimba.
Thank you, everyone, and thank you, Gabe. Good afternoon, everyone. Welcome to today's talk. Sorry. I have no disclosures. So today, like was mentioned, we'll be looking at history taking an exam in neurology. And I'll start off with a case. And maybe, Gabe, are we able to just do a poll here? This is just part of introducing us to the topic that is going to be at hand. Can someone? Okay, thank you. So we have a 40-year-old man who we're going to call patient X, presents to the outpatient clinic with bilateral lower limb weakness. Which of the following questions will be helpful in localizing and formulating a diagnosis? So we are getting some feedback. Okay. Okay, do we still have more people voting? I think we are ready to end our poll. Okay, so I'm just gonna share the results. So we have D, ascending weakness, 73%. And we also have B at 23% and E, nobody knows. Okay, thank you. Just keep this case in mind. And we're gonna use this case to just illustrate what we're talking about today. So thank you. All right. Okay, so the objectives for this talk today are to discuss the value of history taking and the neurologic exam. We're also going to outline the steps in taking the history and doing the neurologic exam, and then describe how both history and exam help us to formulate a diagnosis. So really, when we talk about history taking, we want to establish localization. The other talk we had 2 weeks ago, we had discussed on localization. And now we just want to see what the history is able to do for us in terms of localization. So when it comes to history, basically what we want to do is to define the where the lesion is. Where is this problem coming from? And the reason that is because each level of the nervous system has a particular differential diagnosis for the types of disease processes that can affect it. So let me just explain a bit on that. The second aspect is the what. What is the lesion? And with the what usually helps us is the time course. Again, time course, that is the period in which the symptoms develop, is important for us because different disease processes will emerge and develop over different time frames. So let's go to the where. We're all familiar with the central nervous system, which is comprised of the brain and the spinal cord, and then the peripheral nervous system. So if you think about localization and you're thinking about the where broadly, you can categorize that into the central nervous system, which is comprised of the cerebrum, that is your two hemispheres, and the different structures within the brain. The brainstem, which is like the connector between the brain and then the spinal cord. So those are the areas we consider the central nervous system in terms of localization. The peripheral nervous system has to do with the spinal roots, the dorsal root ganglia, the peripheral nerves, muscles, as well as the neuromuscular ganglia. And if we remember our anatomy, the way these are connected to each other, and we'll come to how this is important in terms of localization, the way these are connected to each other. So you have the nerves or the neurons starting in the brain. For example, if you want to do a voluntary movement, that is movement of your muscles, you want to lift a limb, you have the neurons beginning in the cerebrum or in the brain, and then they come down. Those are the upper motor neuron fibers, as we call them. Sometimes we call them corticospinal or corticobulbar neurons. We also, sometimes you'll hear the term pyramidal tracts. So they will arise from the central nervous system, the brain in particular, come into the brainstem in order to supply the cranial nerve muscles, or rather the muscles that are innervated by the cranial nerves. So there's the first order neurons, which will come from the brain into the brainstem, and then they do some form of relay to connect to the peripheral nerves. So from the nucleus, then you have the connection, another nerve that is going out to the particular muscle. And this is happening at the brainstem level, as well as in the spinal cord. So you have a nerve, for instance, that's going to the limb. You want to move a muscle of the leg. You have the nerve that starts from the brain into the spinal cord. And depending on the level, it makes a contact with the next nerve, which is your peripheral nerve. And so with that division, you realize that even the way symptoms will present will follow this pattern. So for example, when someone has got lower limb weakness, as we have seen in the scenario above, you are thinking about, if this is localizing to the spinal cord, you're thinking about someone who presents with weakness that, for instance, if the lesion is in the spinal cord, it means that from a certain level, all the nerves that are going down, these are still in the central nervous system, which is the spinal cord, all the nerves going below that point are going to be impacted, meaning that the nerves, including the peripheral nerves, and even the function of those nerves will be impacted at the same time. And so someone is going to have weakness that is symmetric. This is different from peripheral nervous system. The weakness that you might see there would tend to be an ascending type of weakness. For instance, if you're having damage to the peripheral nerves, you have this ascending character of the weakness. And so it becomes very important for us to establish the where just by understanding which part of the nervous system the patient is presenting with, or the symptom that is the patient is having an understanding of how the weakness developed is very important in establishing the where. Moreover, when it comes to localization and in terms of the where, we also think about particular structures within the central nervous system. So for instance, movement disorders tend to be localized to the basal ganglia. So things like Parkinsonism, myoclonus, tremors will localize to the basal ganglia. So if someone is going to come in with tremors, you know automatically, or someone who is coming in with slowing of movements, Parkinsonism, you know automatically that there's a problem in the basal ganglia. Sometimes people have had strokes in the basal ganglia, and years later, they develop symptoms that are very similar to Parkinson's disease, for example. We can also think about tissue type. Okay, is this white matter disease or is this gray matter disease? Is this affecting the myelin versus the axons? So the myelin is that covering that is surrounding the nerves, and then the axons will be the nerve itself within the myelin. And so conditions such as multiple sclerosis, which is in the central nervous system, is affecting the myelin, the covering. And if it's in the peripheral nervous system, conditions such as Guillain-Barré syndrome will also affect the myelin with regards to the peripheral nervous system, that is the peripheral nerves. You can also think about which systems are impaired. So if someone is coming in with weakness, that's a motor problem. If someone is coming in with sensory symptoms such as numbness, pins and needles, burning sensation, you know that the sensory system is involved. And so going back to our question, where we had this gentleman who is coming in with bilateral lower limb weakness, the questions that will help us to determine where the lesion is are actually B, which is, does he have urinary incontinence? C, is he experiencing constipation? And D, was the weakness ascending? And let me just go back to one item which I forgot to mention. When I was talking about the central nervous system lesions, so think about the bowel and bladder, which are a bit further down in the human body. The nerves that are responsible for the function of those organs are going to be within the central nervous system, that is within the spinal cord. And so if there's an impairment in the spinal cord, usually these fibers are going to be impacted. And so you have someone who's got bilateral lower limb weakness. If they are presenting with weakness, with difficulties passing urine or in urinary incontinence, or they're having constipations, they're not able to feel their bowel movements, then in that sense, we know that this is localizing to the spinal cord. And this is what I was just talking about earlier. This is contrasted with someone who is having an ascending weakness. An ascending weakness in the lower limbs would suggest peripheral nervous system weakness, like I earlier alluded to. So to some degree, the where already starts to hint at or define the what. So for instance, in this scenario that we had, we're talking about someone who is having bilateral lower limb weakness. And let's say they have history of also constipation and incontinence. And then you already begin to know that there is a problem in the spinal cord. Okay. Then further history, for example, if they say that the time frame, if this has been going on for the last 6 weeks, it's been slow, it's not been acute, it's not been sudden onset, that now begins to tell you what it could be. Because if it's something that happens very quickly, you think about another differential. So I already talked about what the what does for us. So basically, the timing is what will help us in determining the what. So thinking about our case, we already have established that this is in the spinal cord because it's both lower limbs that are weak. And we are hearing that he's got bowel and bladder symptoms. So we know it's in the spinal cord, and a lesion in the spinal cord is termed a myelopathy. Then we have been given a time aspect to it. So we're talking about 6 weeks, and it is slowly progressive. That's giving us a time period, which is the subacute period. So the next thing someone should be thinking about is what sort of condition can impact the spinal cord over a course of weeks, okay? And it is this same approach that we will apply to other presentations within the within the central nervous system. So for example, if somebody is developed weakness on half of the body, if it happens within seconds, 1 minute they are intact, the next minute they are paralyzed half of body, versus someone who develops weakness on the half of the body that is slowly progressive. So for instance, they start by saying, I've been feeling weak in the right lower limb, slowly it's getting worse. It's now been 2 weeks. And then they follow up and they say, now I'm starting to have same weakness or similar weakness involving my right upper limb. And this has been getting worse maybe over the next 3-4 weeks. And then maybe now they develop also weakness of the face. And you see that there's a difference. There's this prolongation of symptoms developing over a course of time. Definitely at that point, it looks like a stroke just because it's involving half the body. But the progression tells you that it can't be a stroke because, for instance, a stroke tends to be very acute. In fact, we call it hyperacute. It happens within seconds. 1 minute, you're fine. The next minute, you're totally hemiparetic. And so thinking about time course, we classify into hyperacute. This is the symptoms happening within seconds to minutes. Usually these are, you think about etiologies in terms of vascular events like stroke, as I mentioned a bit earlier. if it's the case of the bilateral lower limb weakness that we have in our scenario, you think, could this be a cord compression where the disc herniates and quickly the spinal cord is impacted and suddenly somebody develops a paraparesis? Okay, there are other things that will present very acutely. A seizure is one thing that can present very acutely. Migraines can do that. Metabolic etiologies can also cause a change either in mental state or one part of the nervous system for changes to occur very quickly. We also have the acute to subacute, which is within hours to days. Infections can do that. Things like GBS, I'm sure we've seen people who develop weakness that is ascending within 3, 4, 6 days, they are completely paraparetic. Then we have the subacute course, which is over days to weeks to months. Etiologies that you might think about include neoplasias. They tend to be slowly progressing. Infections like TB, HIV, of course, affecting different parts of the nervous system. And then we have chronic. This is something that is happening over years, okay? So for example, someone is developing memory impairment and it's going on for 2 years and 3 years. That's a chronic problem, like in Alzheimer's disease. Or if it is someone who is developing hemiparesis, like I mentioned, it could be something growing slowly in the brain like a tumor. Okay, if it is something like in the spinal cord, as we were discussing just a while ago in our case, you think about things like Friedreich's ataxia and that sort of thing. But with this rule in mind, it's important to remember that there are exceptions of conditions that are chronic that might present acutely. For example, if somebody's got a tumor that's asymptomatic in the brain, they might acutely present with a seizure. Okay, and when you do imaging, that's when you discover that the reason why they're fitted is because they've got a slow-growing tumor, but they've never had any symptoms. Okay, and then vascular events, we have talked about vascular events giving you an acute picture. But if you're talking something like a subdural hematoma, that can build over weeks or even months. And it's a vascular event, and yet the symptoms can be quite protracted. So once you have established the where and the what with the history, it's important to ask a few more questions with regards to symptoms before the onset of whatever the patient is coming with. Associated features become very important as well. Okay. At the same time, you're characterizing fully your presentation. So if this is a headache, is there something that makes it worse? Is there something that relieves it? What other factors are associated with it? What's the quality? Is it one-sided? Is it the whole head? And then, of course, like all other medical conditions, past medical history is important, medication history, family history, and social history. So let's come back to our patient X. Who's got bilateral lower limb weakness. So now you learn that he's had headaches, he's had fevers, he's had night sweats, he's HIV positive and polycompliant. He develops confusion, daze, and then he also has a generalized seizure. So when you see him the next morning, say after he's had a seizure, you discover that he's confused or he's disoriented. So this will be a poll question. I will need some help here. So other than the spinal cord, where else do you localize his symptoms? So I would like for the people on the group to be able to see if now they're able to use what we have discussed. Okay, so we have the majority going for cerebral cortex. And there are more people voting. Okay. Okay, so all right. So 76% choose the cortex. We have 21% that are saying the peripheral nerves. So the answer here should be the cortex. And the reason, like we had discussed earlier, he's now got seizures and altered mental state, which will localize to the cerebral cortex. Okay. We had talked about this, some of the features that you expect from the different regions of the central nervous system. So this is what I was talking about. So now you have a localization. You've got the brain is involved and you've got the spinal cord involved. And so you're thinking in terms of your differentials. I've got an encephalomyelopathy, which is secondary to, now you begin to think, is this an infectious process? It sounds like an infectious process. He's got fevers, he's got night sweats. You also know that he's HIV positive and is not compliant. Could it also be an inflammatory non-infectious process, something like, could it also be like a neuromyelitis optica? But of course, there are other associated features that you might want to ask to support this diagnosis. Or is this a problem with B12 deficiency, which can also present with altered mental state as well as a myelopathy? So we come now to the neurologic exam. So 90% of your diagnosis, the formulation of your diagnosis, is really going to come from your history. So you must do a very good history. You must be very attentive to what the patient is presenting with, because 90% of your diagnosis is going to come from there. And just a small, like 10%, is really going to help you confirm your diagnosis. Okay? So you want to think about the pathways that are involved when you're doing your examination. You are also thinking about the structures that are involved. You've already established it in your history, but you want to confirm as you do your examination, okay? So, for instance, if it is upper motor neurons that are impacted, there's a way in which the weakness that is affecting the upper motor pathways is going to look like versus the lower motor pattern of weakness. Are there other dysfunctions that you've observed? You'll be able to determine from your examination. So the components of your neurologic exam include the mental status, the cranial nerves, the motor exam, the sensory exam, reflexes, coordination, and gait. And if you see the diagram on the side, it's basically showing you that all of these aspects of the neurologic exam, you can actually map them to one part or the other of the central nervous system, as we earlier highlighted. The first part is your mental status. And essentially, the mental status is as a result of a combination of the function of the reticular activating system, the thalamus or the thalami, and the cerebral hemispheres. So any impairment in any one of these regions is going to impair the level of consciousness. Your reticular activation system is in the brainstem, and this is a network of neurons that are connected to the thalamus as well as to the cortex, really making you awake during, as we live. That's what makes you awake. That's what helps you to filter out what's important and focus and concentrate on what's not important, and focus and concentrate on things that are important. So what is the first thing you want to establish? Is this patient awake? Are they arousable? And if they are awake, are they alert? If they're alert, are they attentive? If they're not alert, can they be awakened by a voice or vigorous stimuli? And once they're awake, can they stay awake, or do they fall back to sleep? I'm sure a number of us have come across patients like this. It's important to remember that terms like lethargy, somnolent, delirious, stuporous, obtunded, or comatose can be very vague, and many clinicians will interpret them differently. Also, the Glasgow Coma Scale is used to gauge the severity of brain injury. So it's basically just going to look at eye verbal and motor response. But the neurologic exam goes beyond all of this and tries to isolate where the problem is and to also make sure that other regions of the central nervous system are intact. So is your patient awake? And if they're awake, are they alert? You're basically trying to establish the integrity of the cognitive function. How do you assess if somebody is attentive? You can ask them to count forward. You can tell them to give you the days of the week forward, the sequence. Are they concentrating? You can ask them to count backwards. Are they oriented to person, to time? It's important to remember that usually when someone is going to be disoriented to person or to self, you start to think more, is this a psychiatric problem? That's where we see a lot of that, okay? Then as you are conversing with them, if they are fully awake and fully alert, are they logical? Are they clear? Do they have appropriate responses? You can also assess for someone who is fully awake, okay? If they're not fully awake and they're inattentive, you cannot go on to assess their memory or other cognitive areas, okay? So this is, assessing for memory is really for those people who are fully awake and engaged. So you can assess short-term memory and long-term. Short-term, you can give them a couple of things to remember, ask them again 3 months later. Long-term, you find out where they were born, who is their first president, which school did they go to, and you can corroborate that with their family members. And then we come to language assessment. These are controlled within the frontal and the parietal lobes. So if you're going to find impairment in the language centers, you know which region of the brain is impaired. Usually that is predominantly the left hemisphere, both in people who are in right-handed and in those who are left-handed. So it's got several components, production of speech, written, can they understand, can they read, can they repeat? And a combination of impairment in any of these domains will give you what is known as anaphasia. That's why you will find people who have a stroke, they might not have verbal output, but they might be able to understand, or they do not understand, but they keep on speaking, and what they're speaking is gibberish. It's important to remember that aphasia and dysarthria are 2 different things. So if someone has got slurring of speech, that is not equated to anaphasia. So going through what you will assess for is, are they fluent when they talk to you? That is the number of words that they're able to produce in a given amount of time. Can they name objects? Can they follow commands, complex commands? You tell them, do this, then do that, then do this. You give them like 3 steps without demonstrating it to them just understanding, and then you see what they're able to do. And then we come to the cranial nerves. There's 12 cranial nerves. The olfactory is for sense of smell. The optic is for visual acuity. 3, 4, and 6 are what helps the eyes to move in all directions. The trigeminal, that's got a sensory component for the face, and also the muscles of mastication, that is your chewing. The facial nerve is what's responsible for all the facial muscles, all this expressiveness that we exhibit on our faces as a result of the facial nerve. Then the vestibular cochlea for your hearing, the glossopharyngeal and vagus are examined at the same time. So that's your gag reflex for 9. And the vagus, you look at the palate to see if it can rise when you ask the patient to say, ah. And then we have the spinal accessory nerve, which is responsible for the turning of the neck side to side. And then, of course, the hypoglossal, which is responsible for the tongue, for the activity of the tongue. At this point, I'd like to just share a few slides from YouTube that basically are demonstrating how these examinations are conducted. So, let's see. I'm just asking if I could okay.
It's not highlighting.
Highlighting. I'm having some technical difficulty here. Oops.
Let's go.
Okay.
This is Sarah from RegisteredNurseRN.com, and in this video, I'm going to be over a nursing assessment of the cranial nerves.
Can they see it?
Yeah.
Okay, great.
Let me just check. You can continue.
Okay, all right. Can you all hear me?
Yes.
Okay, great. So what I'm gonna
We can't see the video.
say again? Can you see the video?
They can't see the video.
You can't see the video.
No.
We just see the cranial nerve slide. No.
Okay. All right. Let me see if I can
Let me
share.
Because of your kind presentation,
Share.
stop share this.
Okay.
And now we can share. Then share sound. Then go to the window.
Yeah. Okay.
Yeah, you can double click.
Okay.
Yeah.
All right. Okay. Okay. So what we're gonna do, I will not go through the entire cranial nerve, but I would just like to highlight a few cranial nerves which I think are important. Obviously, it would be good for us to be able to see how cranial nerve exam is done, and we've included the links at your own time. You can find time to go through the cranial nerve exam. So I will go to. We'll just look at 3, 4, and 6, which is how you do the cranial nerve for the eye movements. Let me just find where it is. Yeah.
S, cranial nerve. 3, which is ocular motor, 4, trochlear, and then 6, which is abducens. And we're going to do several tests to check their function. The first one, what we're going to do is we're going to be looking for any involuntary shaking of the eye called nystagmus. And how we're going to do that is we're going to take our pen light, we're going to hold it about 12 to 14 inches away from the patient's nose. And Ben, what I want you to do is keep your head still, don't move your head, and just use your eyes to watch where I move the pen light. And as you're doing this, you're going to perform it in the 6 cardinal fields of gaze, and you're just going to move it, and you're looking for any involuntary shaking of the eyes. So here we go. Next, we're going to see how reactive the pupils are to light. And to do that, we're going to dim the lights a little bit, and we're going to have the patient stare off at a distant object. That helps dilate those pupils. And then we're going to shine, using our pen light, in at the side. And we're going to see how that pupil responds. It should constrict. And then on the other side, it should constrict as well. So say their baseline pupil size was like 3 millimeters. It should go down to 1 milliliter, and it should happen on both sides. Okay, so Ben, stare off at that object right on the wall over there for me. Okay, and that dilates the pupils, and we're just going to shine light in at this side. Okay, constrict, constrict. Okay, let them dilate again, and then go to the other side, do the same again. And they both constricted in equal size. Next, what we're going to do is we're going to check for accommodation, and how we do that is we turn the lights back on. We just previously had them dim, but we now make it light again. We're going to have him stare off at a distant object. That helps dilate the pupils, and we're going to take a pen light. You can use a pen light finger, and you're just going to slowly move it inward to the nose. And what you're looking for is that those pupils constrict, they accommodate, and the eyes cross while looking at the pen light. So here we go. Stare off in the distance, please. And I don't want you to move your head or anything. Just keep it real still and just follow this pen light, okay? Ready? Okay. So now we can document, because we just nerve 7, which is the facial nerve. So can you close your eyes tightly for me and open them up? Okay. Now smile for me. Frown. and puff out your cheeks. Okay, and he did that with ease, so that cranial nerve is intact. Next, we're going to
Oops. Okay, so that was cranial nerve exam 3, 4, 6. There was also 2, looking at the pupillary reaction 2 and 3, and then facial nerve, which is your facial expressions. Like I said, we won't go through all of them, but when you have some time, you can just go through and find out how it is done. And then after you've done your cranial nerves, you can go to the motor exam. And essentially what the motor exam is examining the whole span, the whole axis. Remember, we have the upper motor neuron nerves that are still going to have an impact on the peripheral nerve, which is eventually going to your peripheral nerve and to your muscle, sorry. You have the brainstem, which is where these upper motor neurons are going to pass through. So any lesion in that region can actually impact the function of your muscles through the spinal cord, to the nerve roots, and so on. When it comes to the motor exam, we're looking at the strength, we're looking at the bulk. Is there atrophy, wasting that can happen if there's been a peripheral nervous system problem, if the muscles are not being used. For example, if somebody suffers a stroke and many years later you look at their limb, you discover that it's become much smaller than the other. So you look at the muscle bulk, you look at the tone, it can give you an idea whether you're dealing with upper motor neuron weakness or lower motor neuron weakness. And then we also look at the tendon reflexes. So again, we will not go into all of the examination, but I'm hoping for these 2 videos, we can just look at how they do the upper motor, that is the upper limbs, okay, examination of the motor for the upper limbs and then examination of the motor for the lower limbs. I lost it.
Hi, my name is David, and I'm in the medical students. Just confirm your name and date of birth.
See?
Yusuf Smith, 1st of January 1993.
Hi, Yusuf. I'd like to perform an upper limbs neurological examination today. It's going to involve me testing the nerves in your arms and getting you to do a few movements. Is that okay?
Sure.
Are you in any pain today?
No.
Okay.
We can see the video, but it's stopped right now.
So if you can lift your arms up like this for me, just with your palms up, and close your eyes and hold it there.
Can you see it now?
Good. Now open your eyes and relax your arms. So I'm just going to test the tone in your arms now. So if you just keep them floppy for me, I'm just going to move them around, okay? So. Okay. Good. Now open. For me, I'm just going to move them around, okay? So. Hi, my name is David. I'm one of the medical students. Can I just confirm your name?
Okay, so this is for the upper limb and how you might examine it. So supposed to stop.
The tone in your arms now. So if you just keep them floppy for me, I'm just going to move them around, okay? So. Okay. Just going to test the strength in your arms now. So if you can just lift your arms up like this and just keep them up. Good. And keep them up. Good. And just relax them down slightly. And don't let me pull them up. Good. Don't let me pull them up. Good. Arms up like this in front of you. And just keep them there. Good. And keep them there. Good. And push out against me. Good. And push out against me. Good. Arms up in front of you. And just cock your wrist back. And just keep them there. Good. And just bend them forward. Don't let me lift them. Good. Great. If you can put your fingers out straight in front of you and just keep them up. Good. And keep them up. Good. And spread your fingers for me. And just keep this fingers now. So if you just let your arms go floppy, I'm just going to move them around. So I'm going to test your sensation now with this cotton wisp. It's going to feel like this. I want you to close your eyes and just say yes when you can feel it.
Yes. Yes.
Was that the same on both sides?
Yeah.
Good.
Yes. Yes.
Same on both sides?
Yeah. 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 Yes. Yes.
Is that the same on both sides?
Yeah.
Okay. I'm going to test some of your sensation just with this sharp pin now. It's going to feel like this. Can you feel that as sharp?
Yeah.
Okay. So I want you to close your eyes for me and just say yes when you can feel it as sharp. Okay.
Yes.
Okay.
Yes.
Was that the same on both sides?
Yeah.
Okay.
Yes. Yes.
Good. Same on both sides?
Yeah. Yes. Yes.
Same on both sides?
Yeah. Yes. Yes.
Same on both sides?
Yeah. Yes. Yes.
Good. Same on both sides?
Yeah. Yes. Yes.
Same on both sides?
Yeah.
Now we're going to test the vibration in your arms. I'm going to use this tuning fork. Can you feel that vibrating?
Yeah.
Good. Okay. So I'm going to test this in your arms. Close your eyes. Can you feel that vibrating?
Yeah.
Good. Tell me when it stops.
Stopped.
Good. So I'm just going to test some of your joint position sense now. Okay, so I'm going to move your thumb up and down. Okay, so this is up and this is down. I want you to close your eyes for me and tell me whether I'm moving it up or down.
Up. Down. Up. Up.
Okay, I'm going to try the same on the other side. So this is up and this is down. Close your eyes for me and tell me whether I'm moving it up or down.
Down. Down. Up. Up.
I'm just going to test your coordination now. So with this finger, can you touch your nose and touch my finger and go back and forth? Good. Try the same with this finger. Good. Great. And can you place one hand over the other like this and turn it over and go back and forth as quick as you can? Good. And try the same with the other hand. Good. That concludes the
All right. So in that video, we're just looking at the upper limb exam, and a similar approach is done for the lower limbs. Through that exam, we were also able to see the sensory exam, which we'll come to a little bit later, and also coordination. Let me just... Now where's my video?
So I'm now going to test some of the tone in your legs. So you just let your legs go loose and floppy. Okay.
Very good.
That's your ankle. I'm just going to come out. Okay. So I'm now going to test some of the tone in your legs. So if you just let your legs go loose and floppy, okay? Good. And just relax your ankle. I'm just going to pull back on it, okay? So I'm going to test the strength in your legs now. So if you can lift this leg straight up off the bed and stop me from pushing it down. Good. Just relax this and lift this leg up straight off the bed and stop me from pushing it down. Good. And just relax it. I'm going to place my hand underneath your leg. If you can push it down into the bed. Good. And stop me from lifting it. Good. Great. So I'm just going to bend your knee. So bring your ankle back towards you. Good. And relax. I'm going to bend your knee and bring your ankle back towards you. Good. Now if you kick out against me, good. And kick out against me, good. And can you bring your toes up towards you and just keep them up? And keep them up. And can you push down against me? Good. And push down against me. Good. And just bring your big toe up towards you and keep it up. Good. And keep it up. Good. Now if you turn your foot in, that's great. Good. And turn your foot in. Good. And turn this foot out. Great. And keep it out. Good. And turn this foot out. And keep it out. Okay, so I'm just going to tap some of your reflexes, just both at your knees and ankles. So if you just relax your leg as much as possible. So I'm now just going to bend your leg and just let it flop to the side. Same on the other side, so we'll bend your leg. Just let it flop to the side. I'm now going to test a reflex in your foot. I'm just going to use this dull end of this tip. It may feel a little bit ticklish, okay?
All right. Are we able to see the screen? Okay.
Yep, we can.
Okay, great. Yeah. So that was the exam of the upper limbs and the lower limbs. And it's important to remember the pattern of weakness that you might find, whether it's upper motor or it's lower motor. In your own time, you might be able to look at all of these. Suffice to say, if you found spasticity and there is weakness, you might think that this is an upper motor lesion, whereas it's hypotonic, then you think about a lower motor localization. And then when it comes to the power, there's grading as well. So full power is going to be against resistance. If there's, which is 5. If you have against resistance and against gravity, then it's about 4 plus or 4 minus. If it's only against gravity, which means the patient is only able to raise the limb off the bed, for example, and you cannot, they cannot sustain or resist your force on them, then that's a grade 3. If they're even unable to raise it off the bed and either limb and they can only do side to side, then that's a 2. A flicker of moment is a 1. And when there's absolutely nothing, that's a 0. Sensory exam, these are the sensory modalities you want to examine for. The video was able to show us pinprick, vibration, as well as perception. We can also do temperature. And then we also looked at the tendon reflexes. We have the Babinski sign and the Hoffman sign. So the Babinski sign was demonstrated in the lower limb exam. I will not share it here, but I will share these videos when you can also have a look at them. The Hoffman sign is more like a Babinski in the upper limb, okay? So you flick the middle finger and then you look at the forefinger, the first finger and the thumb, and you see them coming inside by a reflex way. Let me see if I can still share this. And then we already looked at the the coordination exam. So we did the finger nose, and then there was also the alternating hand movement. And then in the lower limbs, you can also assess coordination by doing a heel to shin type of examination. You can also ask the patient to walk in tandem, that is 1 foot in front of the other. Well, after you've done the motor exam, the sensory exam, coordination, you must also assess for gait. And there's various gaits that you might be able to appreciate, including a spastic gait, one that we see in somebody who suffered a stroke, for example, a steppage gait, ataxia, and Parkinsonian gait. Again, this is a site where we can have a look at some of those gaits. I will not share them here right now. Suffice to say, a spastic gait, if you can think about somebody who suffered a stroke, you might be able to see what a spastic gait looks like. So their lower limb is sort of extended, it's straight, and then the foot shuffles on the ground, and the arm is going to be uplifted, rather flexed at the elbow, and there's a way in which they rotate as they walk to demonstrate a spastic gait. A steppers gait is one where there's foot dropping, so the foot is not able to reach the, hello? The foot is not able to reach the ground and cover the ground nicely. And instead, at the ankle joint, the foot flexes down or plantar flexes. And so it looks floppy when they walk, and it looks like they're stomping as they walk. So back to our patient, let's say that's the patient who's got bilateral lower limbic weakness that we started out with. You find that the upper limbs, the muscle power is 5 out of 5. In the lower limbs, you grade it at 1 out of 5. They've got spasticity, they've got upgoing toes, which is your Babinski, and you find a spinal level at T6. At this point, is anybody able to put everything together and say where the problem is? Anyone on the call? All right, so at this point, with all of these features, so you've got spasticity in the lower limb. Okay.
Can I try?
Yes, please.
So I think there's the issues around the spinal cord. Perhaps the person has TB spine.
Okay. All right. Thank you. Thank you for that. And I agree. So we're saying it's in the spinal cord. The spinal cord is your central nervous system location. And we know that this central nervous system location, because that will be your upper motor fibers, where they're still passing yet to go and synapse with the peripheral nerves. And we said that in the central nervous system, a lesion in that area will present with certain features like spasticity or hyperreflexia, as demonstrated in this patient. We also have reflexes like your plantar reflex or your Babinski. So that already tells you that this is in the spinal cord. You also have a spinal level, which again points to a problem in the spinal cord. And so at the end of the day, you have a conceptual framework, you have an idea of where the problem is and the possible etiologies in terms of understanding the what. So he's HIV positive. You can think about all those CNS OIs. You can think about your TB. Of course, epidemiology becomes important in this setting. Our setting, for example, TB would be like top on your differential. So in summary, the takeaway from this talk really is that history is very important in helping us to localize as well as your examination. You want to know your where. That's very key, and you can get that from the history. Time course is what will help you determine the what, and remembering the time frames that we talked about. So hyperacute, acute, subacute, and chronic, and different processes will present in a different time progression. There's those that will be hyperacute, there's those that will take a bit of time, and that will give you an idea of the what it is. Finally, an examination is very critical because then it confirms or refutes the hypothesis that you would have generated in your examination. These were my reference sets, and at this point, questions are welcome. Thank you.
Thank you so much, Dr. Chishimba. Before we go into the questions, I just want to introduce one of our subject matter experts who can also assist in helping to answer these questions or any other questions that anybody might have about the topic that was covered today. So today we have with us Dr. Melody Asukile. She's a consultant neurologist at UTH, also one of the first neurologists to be trained in Zambia. She has a particular expertise in electrophysiology, so seizure and neuromuscular disorders, and completed her fellowship in Cape Town, and is currently working on a PhD. But so she is with us today, and thank you so much for joining, Dr. Asukile. So for the participants, please feel free. You can feel free to speak up. You don't have to raise your hand. And if you would prefer to just write something in the chat, you can do that as well, and we can address questions in the chat. But as Dr. Chishimba said, like what or has here, what questions come to mind? How does the information that you just learned relate to the experiences you've had treating and seeing patients in Zambia? And I guess while people are thinking of questions, maybe we can have Dr. Asukile, if you'd like to just share any thoughts about the topic that come to mind.
Thanks, Dr. Nick. I think Dr. Chishimba did a really great job giving us an overview of assessing a patient with a neurological problem. I'm not sure if I have anything to add. Maybe just a reminder to everyone our thinking process when we see someone with a neurologic syndrome, because it's
I think maybe your voice cut out, Dr. Asukile. I'm not sure if I'm the only.
Hello? Oh, sorry, I got muted. Can you hear me?
Yeah, we can hear you now.
Hello. Can you hear me?
Yes, that's much clearer.
Okay, sorry. Yeah, so I was just saying that just a reminder or to emphasize what Dr. Chimba was saying, it's always important when you find a neurologic problem to ask yourself where in the nervous system can this be? Because there are times when you can have symptoms or presentations that do not fit anywhere in the nervous system, which may suggest there might not be a nervous system issue. So you ask yourself, is this central or is it peripheral? And then sometimes it can be both. And then after that, then based on the epidemiology in your region, based on what's most common, then you think, okay, what are then my differentials? So it's really important, for example, the case we were given of someone with a spinal cord problem. And so from your assessment, you find that this is a central nervous system problem of presenting of lower limb weakness. So in that case, then your differential, for example, cannot be Guillain-Barré syndrome because that's a lower motor neuron syndrome. So it becomes really important to say, where is the location? What signs do I have? If I have upper motor neuron signs, I need a diagnosis for a problem that's in the central nervous system. If I have lower motor neuron signs, I need a diagnosis that fits in the peripheral nervous system. And that becomes quite helpful. Then the only other thing as well is just the importance of that order of the neurological exam. We understand that many people taking this course, you are not going to be neurologists, and we're not expecting very detailed examinations. But it's really helpful if you think about all the different steps and say, okay, can I check something in the mental state? Can I check something cranial nerves, the motor, sensory, coordination, and gait? You'll find that when you follow that order, it helps you to localize where the problem could be. And it then also subsequently helps you with the differential diagnosis. All right, thanks.
I can see.
Oh, sorry, I was I was completely on mute, but I was.
Oh, you were talking.
Yeah,
So
yeah, I'm
I
so
was
sorry.
thinking, like, oh, did anyone hear anything I said?
No, I apologize. I was completely on mute, but thank you so much,
Okay.
Dr. Asukini, for your thoughts. And I was just I was going to add to recap and reiterate what Dr. Asukile said and what Dr. Chishimba has said through her whole lecture. Just the importance of localization in neurology, and just to circle back to a part of the conversation we had last week. That localization is really something that belongs in every specialty, right? So the example we talked about last week was that, like, for instance, in a lung exam, whether you hear crackles versus wheezes is going to tell you whether the problem in the lungs is in the alveoli or is it in the airways, right? Or with the heart exam, depending on what sounds you hear, like an S3 would direct you towards there being a problem with the structure of the ventricle versus murmurs directing you towards thinking that there might be something wrong with the valves. And so it's not, we actually localize in every medical specialty, but in neurology, it becomes particularly important because, as Dr. Chishimba and Asukile have mentioned, right, where the problem is occurring in neurology and, tells you what are the possibilities on that list, on that differential. Like, what are the, and because the nervous system is such a complex system, localization becomes even more important, right? So if we localize, just as Dr. Asukile was saying, like if we localize to the neuromuscular junction, we're not thinking about a stroke because strokes don't happen in the periphery, they happen in the CNS. So that, just to kind of reiterate Dr. Asukile and Dr. Chishimba's point, how important it is localization is just so central to neurology. And one other thing that I wanted to kind of add as well is just, using the review of systems to help with the localization, right? So, for instance, even symptoms like, as Dr. Chishimba had mentioned, there are some symptoms that don't seem neurologic at first sight, but they actually help us localize within the nervous system. So Dr. Chishimba used the example of bowel and bladder problems, right? Maybe that, you could think offhand that's not a neurologic problem, but in the case she shared, that actually helped us localize to the spinal cord, right? Or, if you're taking you're evaluating somebody with a peripheral neuropathy and you find out through the review of systems that they have early satiety or constipation, right, which are autonomic findings, right, that can help you further understand A, that this is a peripheral nerve process, and B, what kind of peripheral nerve process it is. Or a third example that came to mind as Dr. Chishimba was talking was, shortness of breath, right? We think about that as a lung problem. Sometimes we think about it as a heart problem. But somebody who has trouble lying breath, or somebody who has trouble with shortness of breath, that's notable in particular when lying flat. Sure, that can be a sign of congestive heart, be a sign of diaphragmatic weakness, right? So just to be targeted and intentional and think about how these non-neurologic symptoms that you get in your history can actually help you localize as well. Let me hand it back over now to Dr. Chishimba.
Okay, thank you. Thank you so much, Dr. Skile and Dr. Snare. There was let me see, I think there's something in the chat. Let's see. Okay, somebody responded. They were trying to find out what classifications we use to ascertain power grading. So I think the most widely used is the what's it called again? Research medical scale. Yeah. So the one that goes from 0 to 5. Yeah. Sorry.
Yeah, MRSC. Yeah,
yes.
Medical Research Council.
Yes, Medical Research Council. Yes. Yeah. So I don't know if anybody else has any thoughts at the moment. Otherwise, I suppose we can, Dr. Snee, I'll probably hand it over to you.
Sure. Yeah. We have until at 15:30. So if people do have any other questions at all about anything, please feel free to ask. Otherwise, we will close the session. So, but please, anybody, please feel free to speak up if you have any questions. But otherwise, I'll give it like one.
Hello, did you drop out, Gabe?
Can you hear me?
We couldn't hear you before that.
Oh.
Maybe you could just repeat.
Okay. Yes. Sorry about that. Yes, I was just saying maybe we'll wait just 1 minute more just to make sure that nobody has a last minute question, but otherwise we will close the session maybe at 15:13.
Yeah. People are free to even share experiences if they've come across a patient like that.
Okay, well, I guess for now we'll just say that we'll close the session. So I want to thank Dr. Chishimba for her time and expertise in providing in giving that great talk on the history and exam, and Dr. Asukile as well for her expertise. and insights. For those of you still logged in, please feel free to post in the Neurology Made Easy WhatsApp group if you have any questions. And otherwise, we'll just look forward to our next session in 2 weeks.